We are live.
Dr. Shamik sir, please. Good morning, all. I am Dr. Shirish Thorat, President of VOS and MOS. Friends, on behalf of MOS and VOS, I welcome you all for this very important webinar. Friends, as you know, the keratoconus poses unique challenges in our practice, and there are many underdiagnosed cases of keratoconus. So, early detection and treatment is key to success. I'm thankful to MOS and VOS Scientific Committee for curating this webinar so nicely that every topic, right from the clinical diagnosis to the advanced treatment, is like medical treatment and surgical treatment and contact lenses, all topics are getting covered. We have with us our renowned speakers for today's webinar who are masters into their fields. And I'm thankful to Dr. Ankit sir, Dr. Palak madam, Dr. Anupam sir, Dr. Sahil sir, and Dr. Saujit sir. My special thanks to Dr. Colonel Vijay Sharma sir, Savita Rao, Dr. Sangeeta Wag madam, and my role model and guiding force, Dr. Praveen Krishna sir. A special mention here is Dr. Sahil has accepted our invitation yesterday only, as Dr. Anupam is suffering from viral fever. This shows its command on these subjects. Friends, without much ado, I'll hand over these proceedings to Dr. Ajay Kulkarni sir. And I'm sure this is going to be a great academic feast for everyone. Thank you. Over to you, Ajay sir.
Thank you, Dr. Shirish. A very good morning, and I welcome all of you. And without wasting too much time, we'll start straight away, go to the first presentation. And I would like to invite Dr. Ankit Harwani to go ahead with his talk, making an important point that we should not turn our back to the basics. So back to basics. Dr. Ankit, please.
Thank you, sir.
Please share your slides.
Yes. Is it visible?
Yes.
Yes, sir.
Shall I start now?
Yes, please go ahead.
Okay. Thank you. Good morning, everyone. I would like to thank MOS and VOS office bearers for giving me this opportunity in which I will be discussing about the clinical diagnosis of keratoconus. So I'll start with the basics of clinical examination and then move on to the investigative modalities used in diagnosing keratoconus. So we all know that keratoconus is an atretic disorder, and confirmatory diagnosis of keratoconus can only be done through investigative tools. But yes, we should never neglect the common clinical examination points, history points, which aid in diagnosing the disease. So keratoconus patient in early stages may be asymptomatic. Then as the disease advances, the patient may complain of progressive blurring of vision, shadowed vision, or rarely dry eye symptoms also. Patient may give history of frequent change in refractive error, use of contact lenses. Family history, though not helpful in managing the disease, but may aid in the diagnosis. Frequently, patient gives history of eye rubbing, and association has been established between eye rubbing and keratoconus. We might also want to ask or look for the ocular or systemic association like ocular allergy, atopic diseases, connective tissue disorders, and Down syndrome. There are others also, but these are the few which are commonly seen. So coming to the clinical examination, in retinoscopy, we will see the reflex of retinoscopy having a scissoring effect, which occurs due to the irregular astigmatism that the patient is having due to abnormal shape of the cornea. This test is highly sensitive and should always be performed in a suspected case of keratoconus. The other sign is an oil droplet sign, which is seen after dilating the patient in retroillumination. Then in reflection, we will see high level of astigmatism or high K readings in keratometry. Then on slit line examination, the few prominent signs which are there are increased visibility of the corneal nerves, thinning and protrusion may be seen, but these are seen only in advanced cases. Fleischer ring, which signifies the deposition of hemosiderin in basal epithelial layers. And another significance of this ring is that it denotes the base of the cone. The deposition occurs because of the tear dynamics, which get affected because of the protrusion. So the hemosiderin tends to get deposited at the base of the cone in the basal epithelial layer. Then Vogt striae may be seen in moderate to advanced cases, which are nothing but the folds in Descemet's membrane or the posterior stroma. The other signs which are usually seen only in advanced cases are Munson sign, which is V-shaped deformity of the lower lid, as can be seen here. This occurs due to the abnormal shape of the cornea. Then Rizzuti sign is also there, in which we see a conical reflection on the nasal limbus when light is shown from the temporal side. Then subepithelial or anterior stromal scars are seen because of breaks in Bowman's membrane. Elevated corneal nodules also are seen in a few advanced cases of keratoconus. Exact etiology of this is not known, but it has been proposed that this may be due to the change in epithelial integrity and also migration of fibroblasts at the apex of the cone. The last is hydrops, where there is a Descemet's membrane break and the fluid aqueous tends to seep into the cornea and causes acute edema. So coming to the investigative modality, there are many modalities available, but as far as anterior segment surgeon or cornea surgeon point of view, the most commonly and widely available and most reliable tool is tomography. So what is the difference between tomography and topography? The topography, it gives only two-dimensional information about the frontal surface of the cornea only. That's all it provides. So previously, initially when only Placido-based topographer were available, we used to get only topography data for that anterior surface. There was no data for stromal or posterior corneal surface. So then came the tomography devices, which gave 3D sections of the cornea and information about anterior, stromal, and posterior layers of the cornea. So basically, there are three types of tomographers: Placido-based, Scheimpflug camera-based, and OCT-based. I won't go much in detail about the how to diagnose the case of keratoconus in topography, because there is already a separate talk on this topic. So I will just overview about the topography. So there are various indices available. So the local indices, which we can easily see in any topography or tomography images, are the central keratometry reading. If it is more than 47.2 diopter, then we should suspect keratoconus. Then inferior superior keratometry reading difference. So in this, the superior 5 points, average of 5 points of keratometry reading is taken at 3 millimeter diameter from the flattest meridian, and it is subtracted from the inferior average of 5 points keratometry reading. If the difference in diopter is more than 1.8, we should suspect a case of keratoconus in such cases. Then there is a skewing of a radial axis, which can be seen in anterior sagittal map. So we can see that two steep areas, the axis of these areas are fairly deviated from each other. They are not linear. And if this deviation is more than 20 degrees, keratoconus is suspected in such cases. Another index is a Kalosy-Foggy apex curvature gradient, which measures the change in dioptric power per millimeter in the horizontal or vertical meridian. The values given here are for horizontal meridians. And in keratoconus, if it is more than 2 diopter change per millimeter, It is if the change in diopter per millimeter is more than 2, it is described as keratoconus. So coming to the newer diagnostic modalities, although topography gives us fairly sufficient data to diagnose keratoconus, but due to lack of sensitivity and specificity in early keratoconus cases or pre-topographic keratoconus cases, there was a need for newer diagnostic tools to diagnose such cases because those pose the greatest challenge in our clinical practice, especially in refractive practice. So the newer modalities which are available now are OCT imaging, in which we can map the epithelial layer and see the changes in epithelial layer or Bowman's layer. So if there are changes like focal epithelial thinning at the apex, Bowman's layer thinning, then these changes can help us diagnose preclinical keratoconus cases. Then came corneal biomechanics. Corneal biomechanics is basically a response of corneal tissue to an external force. This response is recorded through a camera in devices like ocular response analyzer and Corvus ST. These devices have become very popular because of their higher sensitivity and specificity in diagnosing early keratoconus cases. One of the indices in Corvus ST, which is the TBI, it has shown in the literature to be 100% sensitive and specific for keratoconus. Then confocal microscopy allowed us to image the layers of the cornea in detail, like epithelium, Bowman's membrane, corneal stroma, corneal nerves, which helped in picking up early changes in the corneal layers in keratoconus. Then polarization sensitive OCT is also there, which gives a further ultrastructural view of corneal layers. Then there's Brillouin microscopy, which is similar to corneal biomechanics devices. But the difference here is that this device measures the corneal biomechanics directly, as compared to other devices, Corvus ST and ocular response analyzer. Those devices, they measure the corneal biomechanics indirectly by an external force, by giving an air puff to the cornea. But this Brillouin microscopy, this measures the elastic properties of the cornea by light waves and acoustic waves. So this is the advantage of this device over those. Then finally, lastly, there are peer biomarkers like MMP9, interleukin, tumor necrosis factor alpha, and tear total protein, which can be measured through KIT for diagnosing keratoconus cases. So to summarize, for routine clinical practice, proper clinical examination, history taking, and mainly topography. And if we have resources, then one of the corneal biomechanic device will help you more than enough to diagnose any case of keratoconus, I feel. Thank you.
Thank you, Dr. Ankit, for comprehensively covering the spectrum of investigations and clinical science. Just one or two comments on this, and then I would request Dr. Swapnil to further the proceedings. I'm sure most of you are not doing retinoscopy or even putting the patients on autorefractometer personally, because most of the centers will have optometrists doing that. So this is the first contact with the patient, which often is missed. If you just look at the shape of the keratometry Myers on autorefractometer, if you see a horizontal egg or obliquely deviated egg, that is the first indication before actually you put the patient on slit lamp. In history, I would stress on asking the patient about their screen exposure, because many times it is not the allergy which is responsible for continuous eye rubbing, but it is evaporative dry eye, which is brought about by excessive exposure to the screen. So these are the 2 points which I would highlight. And of course, whenever you have a doubt, we have a plethora of investigations available to us to actually label the patient, whether the patient has keratoconus and whatnot. So with this, I would ask Dr. Swapnil to take the proceedings further and invite the next speaker. Dr. Swapnil.
So next, what is the order of this thing? Prabhat, you had changed some order, right?
No, that will be at number 4 and 5.
Yeah, Dr. Sahil is second. So
Yeah.
this is his talk.
Sahil is second. Okay, so I would invite Dr. Sahil Goel, who is an ex-LVP cornea, and he's practicing in Ludhiana in medical college as well as in private practice. He is going to talk about tomographic diagnosis of keratoconus and give us different clues where we can diagnose keratoconus nicely on the topography. So Dr. Sahil, over to you.
Thank you, Dr. Swapnil. I was a last minute entrant. I was told that this presentation is mainly for general ophthalmologists, so I'll try to keep it simple, basic, and to the point. We evolved about corneal curvature measurement from a simple central 3.4 mm keratometry to entire front surface video keratography using placido disc based imaging, which captured the anterior corneal surface 6 to 8 millimeters based on reflection from the placido disc. And subsequently, we moved on to optical sectioning, which extrapolated from anterior surface the thickness and then the posterior corneal surface. This is how optical sectioning was done. No matter what topography or tomographer we move on to, the basic still stays the same. The original 30-year-old Rabinowitz criteria. These two continue with the basic of keratoconus diagnosis: central keratometry more than 47.2 and inferior superior asymmetry more than 1.4 diopters. There were multiple indices, KPI, KISA index, which nowadays we don't use much. But inferior superior asymmetry is the first thing and the foremost thing that is a link or a suggestive of keratoconus or asymmetry in the cornea. We started off the tomographers with OpScan. Somehow, with time, it has become obsolete. Nowadays, we have Pentacam, Galilei, and Sirius. And lastly, we have moved to OCT-based tomographers. This is grossly how a basic quad maps looks like. We start with the front corneal surface and look at inferior superior asymmetry and the central K values more than 47.2 or asymmetry more than 1.4 diopters are suggestive of slight asymmetry. Subsequently, we moved on to pachymetry and posterior elevation. Anything less than 500, we should be a little cautious. Posterior elevation is nothing but elevation of various corneal points on posterior corneal surface from a calculated reference surface, which is called best fit sphere. The advantage of newer OCT-based tomographers, it gives you epithelial thickness also to correlate any early elevation. So these are the 4 basic things that we should be looking into a quad map. This is a frank keratoconus. As you can see, there is gross asymmetry, 49 and 52, or in this case, 46 and 53. So there is 7 diopters inferior asymmetry. The cornea is grossly thinned out here, 477, and the thinnest point is highly decentered from the center of the pupil. Corresponding to the thinnest point, the posterior surface is highly elevated. Various tomographers have different cutoff, but grossly 15 to 20 microns is generally the accepted cutoff. If we change the reference surface from a best fit sphere to toric aspheric, the cutoff decreases further, but mostly we are using best fit sphere. And interestingly, as you can see, at the bang point where there is thinnest cornea and there is highest elevation on the posterior surface, you can see the epithelium is also thinned out. The epithelium is slightly masking the early ectasia of the moments or the stroma. This one is slightly less manifest keratoconus. As you can see, there is still an asymmetry of 3 diopters, 42 versus 45. There is significant thinning, 425. At the same point of thinning, the posterior stroma is highly elevated, and you can see the epithelial trying to mask that that gross ectasia. The epithelium is thinned out over here. Sometimes in cases of early ectasia, this epithelial thickness really helps. And this is one of the advantages of newer OCT-based tomographers. Pentacam was the first and is still considered one of the most reliable partners because it came up beautifully with an index called Bellin Ambrosio. So after you have looked at these 4 maps, or for someone who is not really comfortable interpreting these 4 maps, it gave a very simplified version of what is called Bellin-Ambrosio display or BAD index. The first and foremost thing it does is, instead of calculating the reference surface as best fit sphere using the entire corneal points, it excludes the central 3.5 mm area, which is slightly ectatic. It calculates a new best fit sphere excluding the central 3.5, which makes the reference surface flatter. It calculates the elevation by excluding these 3.5, and the difference is finally taken, which it tries to calculate as deviation of front surface and deviation of back surface. Further, it includes multiple other points like thinnest point, pachymetry progression index, that is how the cornea progresses when we progress from central thinnest point to outside in 9 concentric circles. The deviation of central thinnest point from the center, and Ambrosio relational thickness, which is part of the Bellin-Ambrosio display 3. The advantage of this is that when you're confused or when you want a second opinion and you want a friend, it acts as a friend which tells you, yes, what is the overall D. Please remember these individual deviations, yellow or red, are not at all important, as can be seen in this external validation. The sensitivity and specificity of individual D, DF, DB all are extremely poor, such that only 50% of these cases where the individual D is yellow or red would actually be keratoconus. So please do not be misled or falsely diagnose a case of keratoconus based on individual Ds. The final D is what is overall important, which includes ambrosial relational thickness as well. Just simply look at the overall D. The cutoff generally is 1.4 to 2.4 is yellow, which is borderline, and more than 2.4 is red, but you don't even have to go at the numbers. Just look at the color coding to make your life simple. If it is yellow, you have to consider if it is keratoconus, but the diagnosis still remains on interpreting the quad map. If it is red, it is extremely likely to be keratoconus, but it's not a sanctity that if it is red, it will be keratoconus. Various tomographers have come with their own indices. This particular index is of Anterion. As you can see, it also considers like pentacam, pachymetry progression index, thinnest point, and elevation at the thinnest point, Kmax and Kmax, the asymmetry in Kmax. All these points, it gives a final score, and any score which is less than 0 is considered normal. Any score which is positive or more than 0 is considered abnormal. This particular case I have chosen because this particular patient was diagnosed, we went for refractive surgery to our leading ophthalmologist, was diagnosed as keratoconus mainly based on steep cornea. Yes, the cornea is steep, as you can see, 49.4, but there is no inferior superior asymmetry. As you can see, the pachymetry is also good. The posterior elevation is also good. The apical thickness is uniform. You do not see any thinning in the area of any possible ectasia. So this is definitely not keratoconus, even though the cornea is steep. Unfortunately, this patient was cross-linked by someone, which in my opinion does not require cross-linking at all because this is not keratoconus. So steep cornea does not mean keratoconus. If you have normal elevation, normal pachymetry progression index, as can be seen that how the pachymetry progresses from the thinnest point as we go out, and you have no thinning in the epithelium, do not be misled just by a steep cornea into making a misdiagnosis of keratoconus. With this, I would like to end. Thank you so much.
Thank you, Sahil, for filling up for Anupam last minute. Thank you so much. Dr. Ajay, any comments?
Yeah, very crisp presentation, Sahil. I congratulate you for that and making life easier for people who are looking at so many numbers and colors thrown at them by different machines. So important point, one of the important point regarding the last slide or the last example which you showed was, if you have a patient who has abnormally steep cornea, but rest all parameters are within normal limit, look at the limbal ring size. So look at the horizontal white to white. Most of the time, this limbal ring size is smaller, somewhere between 10.5 to 11. To accommodate the same corneal tissue in the smaller limbal ring, the cornea tends up, and that results in a higher K value, which is a generalized higher K value without superior and inferior asymmetry. So very rightly pointed out, 49K does not mean that you should cross-link these patients. So we have to refrain from over-treating our patients without actually labeling them keratoconus, or just on the premise that this patient might develop keratoconus in future. So C3R should be very, very guarded. So I again congratulate you for making things very, very clear. Most of the time, what a general practitioner would face is that patients will come up with topography reports which are from different machines, and it is so confusing. So that is very important to what you highlighted, that look at the final D and the color. I don't really bother about the number. So with this, we move on to the next topic.
I have one quick comment, Sahil.
Yeah.
This basically this is for general ophthalmologists, right? So would you recommend that not every general ophthalmologist can have a tomography, rather pentacam or wavelight or anterion? So is it a good idea to have a basic topographer which will give at least anterior surface idea, and it costs somewhere around 6 to 8 lakhs, and it is a good. Is it a good idea to have it in everyone's practice? Will it support the practice? What is your thoughts on?
I think for someone especially into refractive, at least an anterior.
I'm talking about any general ophthalmologist.
Um,
Would you
so
say that it
general
is an
ophthalmologists,
essential
even
tool to have for everyone to screen the patient? Because these days allergies are rising. All these allergies patient, even with the minor cylinder, we should screen with topography, right? So
Correct.
most of the time it happens that if it is small cylinder, they are not willing to send, or parents are not willing to take the child to some center where tomography is available. So is it better to have the anterior topographer in the clinic for most of the general ophthalmologists?
I would have a slight deviation in thought. What Dr. Ajay suggested, that a lot of us do not pay heed to the Myers on autoref.
Hmm.
So I believe to start with, someone who is a general ophthalmologist, not into even refractive surgery, pay heed to the Myers on autoref. You see any distortion, you think it is keratoconus, you can get the topographic done, because it is very rarely required relatively for a general ophthalmologist from the next door cornea specialist or someone who has it. Second, learn the art of retinoscopy. You start picking up scissoring early. These are two things with which you have no investment at all. Next, if you still have large number of suspicious cases, then you buy a front surface topographer, generally which costs 8 lakhs. And if you are into refractive surgery and you want to screen out and you have the capacity to go more, then you go on a 20 plus posterior corneal surface based tomographer. So there are 3 steps. But first step, you have to learn to pick up scissoring, and you have to start looking at the Myers on autoref.
Yeah, there are as many OCTs as slit lamps in the ophthalmic community. I mean, I'm sure about that. You can get a ASOCT done and look at the epithelial thickening map also, if you have that module. Even that is one thing which can help you, because I've seen like most of the centers will have OCT now.
Correct.
Yeah. Just a quick question. What is the general thought? Where does the keratoconus start? Anterior cornea or posterior cornea?
I personally believe that what we read while growing up, that it always starts with posterior, is erroneous.
Yeah, and
Membrane is weak. Yes, there are cases where we see nothing on the
clinically, our
erroneous on
experience has
posterior.
been different. You see changes
Yes,
on very early changes on the anterior map, and the posterior map looks okay.
correct.
So, that sometimes is very confusing. If the disease starts in the posterior cornea, then we should have something to look at posterior cornea first.
I believe when they had to sell these posterior corneal surface based tomographers and had to make us pay twice as much, they had to
Yeah,
convince
yeah,
us that keratoconus starts from the posterior cornea.
yeah, yeah. So there are a lot of ambiguous areas. So as we keep seeing many patients, the picture will become clear. Okay, thank you, Sahil, for
I had just one
Which,
comment while
yeah,
we are here.
yeah,
A patient coming to you with a constant change in refraction, especially a
yeah,
change in his cylindrical powers, somebody who's complaining of aberrations, a young patient coming with aberrations saying the headlights are looking different or there's ghosting, he shouldn't be labeled as a psychiatric patient who needs counseling. But these are the patients I would pay
yeah,
more attention to and
yes,
screen.
definitely.
Shall we
Okay,
move?
so
Yeah.
Swapnil, go ahead with the next talk.
So next talk is by Dr. Palak, who is a cornea and refractive fellow from Narayan Netralaya, and she's currently practicing at Arihant Netralaya, Nagpur. She's going to talk about medical management of keratoconus. Dr. Palak, over to you.
Thank you, sir. Good morning, everyone. So my today's topic is drops for the cone, medical management of keratoconus. As interesting this topic sounds, it is into too much of research as well. So let us begin with what is the main goal of this medical treatment. So as a surgeon approach to any disease which we see across the eye, first comes the medical management, which we try to do before going directly into the surgical ones. So the goal of this medical management would be, of course, managing the symptoms, halting or slowing down the progression of the disease itself, and restoring or preserving the vision which patient has. So, when we talk about managing the symptoms, I believe this is the most important part of medical management which we have in keratoconus. And when we talk about symptoms, eye rubbing, as it is well established, plays a major role. And I would say this is the only external etiological factor which a patient himself can keep under check. Because many a times in clinic we are asked, ki, what can we do so that our disease does not progress? So I think eye rubbing is the thing, and with many papers across and all the research which has been done, it has been shown that eye rubbing has role both in physical and pathological corneal changes which happen and eventually lead to keratoconus. But when I say this, does not mean that every patient who is rubbing the eye does develop keratoconus. So I think the what research is been saying is the ones who have genetic predisposition to having disease, eye rubbing aggravates it, and also severe eye rubbing, which is persistently happening in patients, allergic patients especially, would lead to this disease. So the research have shown that the youngest patient which have been diagnosed with keratoconus was a 4-year-old with persistent habit of rubbing. And we often find when they want to severely rub their eye, they use their knuckles or extreme force, which majorly causes the damage to the cornea. So the pathway, when we talk about keratoconus, the biomarkers, which I think in the first presentation under the investigation part we had read, all the biomarkers which are being studied in tears or on the ocular surface, which are responsible for the disease progression or have some causative role. This is how the cycle is. Once the allergy is there in the eye and there is itching sensation or the patient is rubbing, there is increased pro-inflammatory the ocular surface and dysregulation of all the homeostasis of the surface. The LOX enzyme, which is important for the corneal stroma, is decreased and other inflammatory factors are increased. So, when we talk about managing the symptoms through medical management, it is very important that any patient who presents with, whether diagnosed with keratoconus or not diagnosed, but is presenting with dry eye, allergic conjunctivitis, or chronic ocular surface inflammation, becomes important to be treated with all the type of drops which we have available with us. When we speak about all these conditions, we are commonly prescribing the drops to them, the lubricating drops, the anti allergic drops, the anti inflammatory steroids. To begin with, if the inflammation is much, I think we need to start the patient on steroids. For general ophthalmologists who refrain themselves from giving steroids at first, but if there is significant ocular inflammation, there is no harm starting with low dose steroids, which specifically acts on the surface. Then we have steroid sparing anti-inflammatory drugs like cyclosporin, and now the newer drug which has come, lifitegrast, which they say has anti-inflammatory properties and also lubricating properties and much more. Still, the studies are yet to be there to say what its role is. But all these drops become the main stay of management if we talk about, if we have to give something for medical management of keratoconus, because the key to halt the progression or preserve the vision of the patient is managing the ocular surface inflammation and preventing continuous eye rubbing in the patients. Now, let us go to other drops which have been investigated, or I would say are majorly under research for treatment of keratoconus. So, this one drop, IV-Med 80, it is the first drop which promises medical cross-linking in the cornea. The active drug component of this drop is copper sulfate, which is necessary coenzyme for lysyl oxidase. The in vivo animal and ex vivo cadaveric human studies till now which have been done has shown that with this drop, there is increased stiffness and flattening of the cornea. This is the only drug which has got orphan status from FDA. They have said that it is twice daily dosage, and it can be a promising drug in future for non-surgical option for keratoconus. Now the other drops which are majorly into investigations, and we can say that there is no established fact that these drops would halt the progression, because there are many cases which without any drops would itself have a very slow progression, or there won't be any progression. Also, even on these drops we can find progression in the patients. So because mmp is one of the enzymes which has been found in the tear film of these patients, its inhibitor doxycycline drops have been into investigations. Though for keratoconus progression there is no paper which says that it would stop or halt the progression. Other investigational drops which are there are the growth factor drops, the TGF beta 3. It is the first treatment which aims at regenerating corneal collagen. So the drop in combination with TGF beta 3 and mild steroids is aiming at corneal collagen regeneration. Then there is Rho kinase drop inhibitor, ripasudil. This is commonly available in the market, but majorly for corneal endothelium activation. And this can be used for acute corneal hydrops if we talk about complications of keratoconus, which we see. Now, other drops which are there are quercetin. It is a natural antioxidant, and it has anti-inflammatory and anti-fibrosis property. So it has been seen in the research again that it can inhibit the scar formation, and it is a key regulator in extracellular matrix assembly. Another medical management, though not drops, but I would say which is coming up and is majorly into research, is the stem cell therapy. So the keratocytes are majorly derived from neural crest, and it can be cultured in vitro and can be injected in the cornea intrastromally for their multiplication. Also, the committed stem cell population, which have the property to maintain themselves, can also be used for stem cells therapy. So while I talk about all these investigation drops and everything, I would like to mention at the end that after all the research, still we stand at a point where managing ocular allergies, avoiding eye rubbing, managing chronic inflammation and dry eyes are the key to medical management of keratoconus. And of course, cross-linking does still is the management for keratoconus progression or halting the progression. Thank you.
Thank you, Dr. Palak. It was an excellent presentation. Any comment, Dr. Ajay, Dr. Sangeeta?
When it comes to managing the allergy on a long-term basis, what is your drug of choice? Will you use sodium chromoglycate or olopatadine or beta-histine? What is your drug of choice?
So, sir, I would first try with olopatadine on long term. If patient is maintaining with that with lubricating drop, I think that should be good enough for them.
What will be the concentration?
Sorry, sir?
Concentration of olopatadine. We have 3 different concentrations available. Which one would you prefer? Because patient compliance on a long term is a major factor. So if any drop which can be used only once a day, it will be more acceptable. So 0.7%.
Sir, yes.
Which concentration?
Sir, I would go for once a day for the patients, because the compliance is increased, and also majorly because these kids, the patients which are there are young population. So school going and then other things, if they have to manage, I think once a day drops with lubricating drop, of course.
Yeah, which is your preferred molecule when it comes to lubricant eye drops?
So CMC 1% for the kids.
Any other thought by the panel or the other speakers?
So what I feel is when we consider anyone having allergy, first we have to consider, is it really a perennial allergy or it is a VKC? Because because VKC is a different ballgame altogether, where we also need to think about inhibiting T cells, or rather, I would say that just giving a tacrolimus or adding a cyclosporin inhibits the allergy at much higher level in the allergy chain, and you may not need olopatadine or any other molecule. My present practice is most of my VKC patients are mainly on tacrolimus or cyclosporin, whatever they can tolerate. And I do not add any olopatadine or whatever drugs, antihistaminic, until and unless patient needs it as a supportive therapy top on that. But I think mainly if we consider VKC, which is mainly associated with keratoconus, we really have to block at a higher level and use these T cell inhibitors than using lubricants or any antihistaminic drugs.
Yeah, point well taken. That we have to differentiate between the types of allergy we are dealing with.
Yes.
Thank you for your comment.
I think some supportive treatment should be basically, the eye rubbing, of course, has been
Yes.
documented, and it eventually becomes a habit with the children.
Mhm.
So I think we have to just stress and give them alternatives like putting cold packs, teaching them how to use the eyelids to rub the eyeball instead of rubbing, wearing protective glasses. Children don't want, like just yesterday, I had a patient who came in severe VKC, eye rubbing, and the parents said, दर आठवड्याला नवीन चष्मा करायला लागतो तो तोडतो. And then I started scolding the boy. I said, how do you break it yourself? He said, nahi, my friend. So then I told the parents, go to the school, tell the teachers. Then the boy quietly said, nahi, nahi, wo na aise bag mein se gir jata hai, niche girta hai. So obviously the boy is not using any protective glasses. So there are small measures which can help the patients. Again, the mattresses, house cleaning, dust mites. So there's a lot to be spoken on this in preventing the eye allergies and its etiology in keratoconus.
I would again add that, especially in children, when VKC and other allergies are not getting controlled, I think we should not hesitate to start them on oral systemic immunosuppression like cyclosporin or tacrolimus. These drugs works like wonder. And I have a couple of patients where I've just observed keratoconus patients on these drugs, even young patients like 16, 17 years old with severe VKC, because I didn't want to do CTR in those patients because of epithelial issues, and they just stop progressing. So I think that point needs to be taken very well, that allergy needs to be controlled very well.
Yeah. Okay, so we go ahead with the next talk. Dr. Prabhat, I would request you to invite the next speaker.
Thank you, sir. So it is my pleasure to invite Dr. Sangeeta Wagh, ma'am, from Pune, one of the most senior cornea specialists in Maharashtra and in India, and who's continued to teach us all a lot over the past so many decades of practice. Ma'am, we look forward to your talk, and she'll be talking about old wine in a new bottle, older and newer modalities of cross-linking. Ma'am, please share your slides.
So, because of my gray hair, I'm always going to land up in a jinx. I hope my slides are visible.
Yes, ma'am.
And I'm audible.
Yes, yes.
So I'd like to thank Shirish, VOS and MOS for inviting me. And of course, I missed the whole point that this is for general ophthalmologists. Well, I don't say general ophthalmologists because all are my friends. So I just thought I would showcase what we are doing at our clinic. But let me pause and just touch upon some very, very important points. Why do we need to cross-link? So the aim of treatment is to stabilize a progressing cone, which means we will treat only when we document progression in the form of change or increase in the keratometry, thinning, and a change in refraction. We do not cross-link every patient of a keratoconus or a KC suspect. The aim is also to regularize the surface irregularity and try to improve the visual outcome. So when will I not cross-link? When a patient is stable, say he's around 30, 35, the patient is more likely to be stable than progress. In younger patients, when there's active VKC, severe dryness, lid or meibomian gland disease, blepharitis, and thin corneas that are thinner than 400 have to be treated with care. Let us not trivialize this process or procedure of cross-linking because it's easily available. We have portable devices. We have people coming to your clinic. Patients are willing to pay. There are your neighboring ophthalmologists who will offer this at much lower cost. Let us not trivialize this, because your patient can land up with disastrous complications like opacification, infections, sterile melts, and we've seen eyes lost due to cross-linking. Let us do it as a procedure in the OT with the same precautions that we would do every other: strict asepsis, properly autoclaved, monitor the cornea with a camera. Do not let your nurse or assistant carry out the procedure after you do the initial deepithelialization. Follow up the patient, patch, antibiotic, bandage, contact lens. I would see the patient every day till the epithelium heals. There are patients who have been ringing in saying day one that there's a problem. The doctor continues to treat them on the phone, and he comes day 3 with a bad infiltrate. Again, we know that we need to watch the machines that we are using, the agents that we are using. So a good calibration, check the calibration before you start the procedure. And also be careful about the riboflavin that you're using. We know there are different types, there are different companies, different schemes, but let's keep it as a serious procedure. So we know that in 1970, Siegel first, this was used in the labs where lysyl oxidase, we know, catalyzes the formation of cross-linking and the different aldehydes. In 1990, Theo Seiler in Dresden in Germany used UV light and riboflavin. Interestingly, he was in a dermatological conference where cross-linking was in use, and then he came back and experimented on porcine corneas. And we know Farhad Hafezi has popularized cross-linking, and there are promising delivery systems which eventually will be in your outpatient. So what is new? Dresden is the standard protocol that we follow. So we have different modes, the accelerated form of cross-linking, then there is pulsed versus continuous. These are the different aspects that I would be discussing. So we know that the Bunsen-Roscoe law of reciprocity tells you that the total energy that is delivered is a product of the intensity and duration. So you can vary these and make sure that the cumulative energy of 5.5 joules per centimeter square is delivered, ideally to a depth of 300 microns. And so this is a question on whether the pathology is in the anterior cornea or the posterior. The very purpose of treating also indicates that the pathology lies in the anterior cornea. The source of light should be 370 nanometers, and that's why we should all use a UV meter to check the machines before we use the equipment. Demarcation is a surrogate line and indicator, and finally you have stabilization of the keratoconus as is documented on further follow-ups for months and years to follow. Long-term exposure, we know, can increase the risk of haze, melts, and infections, and so the need for a shorter, briefer procedure. So either we can do the standard Dresden protocol where after deepithelialization, you soak the cornea with riboflavin for 10 to 20 minutes and then expose the eye to UVA for 30 minutes, continuing to put riboflavin. Interestingly, I was reading an article recently by Farhad himself, by Hafezi himself, in which they have compared continuing to put riboflavin after the deepithelialization and the initial soak, that is when the UVA is on. And they concluded that it was not necessary to continue putting the riboflavin in the later steps. So we know that this is an evolving process and we will not really know what is right and wrong, but then we should look at our own results and then decide what protocol works the best. So the more popular is the accelerated protocol where 9 milliwatts per centimeter square is exposed for 10 minutes. And this is what most of us do because of, well, I think basically it is more to save time than anything else. And we're looking at more and more volumes and a rapid turnover. So a meta-analysis of keratoconus showed that it benefits beneficially by reducing the Kmax. Comparing the standard cross-linking versus the accelerated, paradoxically, corneal thinning was seen more in standard cross-linking. Of course, the dextran-free riboflavin now reduces this incidence, and in our own clinics, we found almost 20 micron thinning post-cross-linking when we were using the dextran riboflavin. The demarcation line is well defined and seen much deeper in the standard as against the accelerated. Endothelial cell count is apparently less altered, and these are studies by Wang et al. And 9 milliwatts per square centimeters is the most favored. So we know that the oxygen levels in the cornea are related to the oxygen difflux, that is the ambient oxygen. And we also know that during cross-linking, oxygen is transformed into the reactive oxygen free radicals, which induce the cross-linking. So if the oxygen conversion is reduced because of the free radicals, then the cross-linking is going to be counterproductive. And that is the rationale for using the pulsed mode, where the cornea gets to breathe between the pulses. And also some of the studies have used nasal oxygen while doing the cross-linking to improve the effects. So whether epi on and epi off, I'm not sure whether my titles are seen, because here I can't see them.
Yeah, they are visible.
Are they visible?
Yeah.
Okay. So the other mode are the epithelium on and epithelium off. So the pulsed epithelium off cross-linking was a one-year result showed that pulsed, where high frequency pulsed UVA was used as high as 35 milliwatts pulsed per second, or you can use the 9 milliwatt with the epithelium on, and the deep penetration was noted at the end of 1 year. Another study claims that more depth of apoptosis and demarcation is seen in the accelerated versus the pulsed. So who should we do transepithelial cross-linking? Does it work? There are mixed reports, but why one does transepithelial cross-linking is because it is less painful, it's faster recovery, there's almost no risk of infection, there's less risk of haze. How do we increase the penetration of riboflavin? Using tetracaine, benzalkonium chloride, EDTA. All these have been studied, where these are put after deepithelization, and then the rest of the procedure is the same. Iontophoresis is also applied to increase the penetration of EDTA. However, only time will tell whether transepithelium really works. In my own series, I did not find it beneficial, and I've stopped doing this. So hypotonic riboflavin is used in the thin corneas, and 30 minutes of exposure is used. Transepithelial accelerated cross-linking versus conventional has also been used, and it is not found to be useful at all. So which are the different protocols that are used? The most standard is the Dresden, which we discussed. Then there were newer protocols which are trying to combine a refractive change combined with cross-linking, like the Athens, the Creighton Plus. The Athens protocol was described by Kananopoulos, where you do a PTK of 50 microns and then a topo-guided partial PRK. Here, they do not aim to reduce the spherical equivalent by more than 1 and cylindrical not more than 2.5. He also applied mitomycin C.02 for 20 seconds and used a high fluence cross-linking. Now, whether mitomycin is counterproductive in reducing the effect of cross-linking, again, we're not sure, but again, it seems to be counterproductive. So in our clinic, we don't use the MMC after the PRK. So in the Athens protocol, they found that the uncorrected visual acuity improved, best spectacle corrected visual acuity improved, the mean K reduced, manifest spherical equivalent reduced, and the Hayes score was not significantly higher. So here we have a patient of unilateral keratoconus with -4 cylindrical 6/9 vision, central Paki of 440. They undergoes the Athens, where we feed in the data, and here we corrected about 2.5 astigmatism. And post-operatively, you had a reduction in the Kmax of 1 diopter, astigmatism by 1.5, and the visual acuity improved from 612 to 6.9. The Creighton protocol combines transepithelial PTK and cross-linking for ectatic disorders. This has been described, and we have our own Vardhaman who was part of this study. The Creighton Plus protocol is combined PTK with PRK, followed simultaneously with cross-linking. Here again, we tried some of these in our clinics, and I found there was significant thinning after the procedure, and we've stopped doing it. This is done very easily with the EX500, where you feed 50 microns flat to do the PTK and then continue with the process in the same way. So here we had a patient whose topography was around 47 and 53. Refractive error was -3 with a -3 cylinder. At the end of 1 year, there was a reduction in the keratometry by 1, the astigmatism by 1, and the best corrected visual acuity was 6.9. So these are the various protocols that can be followed to combine keratorefractive surgery. So how does one start topo-guided PRK and cross-linking? Here we have a 26-year-old lady who had a left eye with frank keratoconus, 1.5 with -3. She was planning a pregnancy. So here again, we know in pregnancy, keratoconus is going to progress. So it is best done prophylactically. Again, for patients undergoing IVF treatment and a keratoconus, even if there's a slight suspicion, I would cross-link. So you export the scans using the Wavelight platform, and we use the topo-guided mode. Here you check the ablation by using the Zernike 0 rule. Here you feed in 0, look at the ablation, and here you see the ablation depth. So we strictly follow ablating less than 40 microns, though there are reports of going beyond 70 and 80 microns. You neutralize the errors and ablate. So here we reduce the astigmatism by 1.5. And the patient did well. How do we know it's working? The left eye preoperatively was plus 1.5 with -3, which at 5 months itself shows a reduction to -0.5. Here the aberrometry again on Zernike's had reduced, the spherical as well as the trefoil. The patient was much better, and when administered a questionnaire was very satisfied. So we have a quality of vision questionnaire ongoing right now at the clinic. We can also do a wavefront optimized pre-RK with the cross-linking. Again, a young lady planning to get married has keratoconus in the right eye. And she has -3 at 80, which is fed into the system. And you just do a PRK after deepithelization, cross-link with the accelerated protocol. Pre-operatively, she was -1 with -5. Post-operative, the cylinder is down to 2 diopters. So in this case, why did we not do a topo-guided? Because when we calculated, we found that we would be ablating almost 65. So we chose the PRK. The comparative studies. So here we did a study where we had 30 patients in both arms. And we found that the topo-guided gained vision by 1 line, whereas in wavefront, 60% showed no change and only 13% improved. The spherical equivalent reduced. And we found that the magnitude of flattening in both was the same. And it was very interesting to see that in topo-guided, the horizontal trefoil and spherical aberration reduced, whereas there was not much of a change in the wavefront optimized. So what did we achieve? We achieved an improvement in the visual acuity and a regularization in the cornea. You can combine this with LASIK as well, but this is something I would not encourage, where in high myopes, you can lift the flap, apply the riboflavin, do the cross-linking and follow up. However, never ablate more than 50 microns, and this is not for patients where corneas are less than 400 microns. What is customized cross-linking? So this is a concept that has been studied and postulated by our own Abhijit Sinare from Narayan Netralaya, where they say that the keratoconus, which is thought to be a genetic disease, does not affect the entire cornea, but is a focal or a local disease, and 6 millimeter zone covering the steepening area is ablated depending on the topography to regularize the cornea. So basically you have a gradient where you have intense or higher energy at the center at a 4 millimeter zone, which tapers off and you have lower energy at the periphery. So what is the advantage? You get better flattening than the standard cross-linking and improvement. Lastly, can we extend this to thin corneas? There have been reports where we all use hypotonic riboflavin, contact lens assisted cross-linking, lenticule assisted cross-linking, that is the SMILE lenticules are used. But there have been nomograms that are designed, and there are online calculators, again by Rohit Shetty's group, where you can reduce the amount of exposure and the duration of riboflavin as well as cross-linking depending on the nomogram that you calculate. So are there any other applications? We are looking at using cross-linking for treatment of infectious keratitis in what is called the photoactivated chromophore treatment for keratitis, that is the PAC-CXL. It reduces the time for healing. There is quicker resolution of infiltrates. It works better in bacterial. Fungal is not known. And the rationale is that the riboflavin and the UVA causes damage to the viral RNA and DNA and causes breakage in viral as well as in bacteria. And the Dresden protocol is most often used. Something different now, something newer, what is being studied and was first postulated by Guillermo Amascua, and riboflavin and the green light is used for treatment of infections with promising results. I think recently Bhupesh Bagga's group has again published very promising results in the treatment of infectious keratitis. Can this be applied for other processes, other pathogenesis or other diseases? So it can be used, or it is being studied in the treatment of myopia control as well as glaucoma. So this was in brief overview of what all can be achieved with cross-linking. Once again, I think we need to be very careful of when and where we apply this, and choose your options and protocols very carefully. At the same time, we can optimize the outcomes by also offering a refractive change, because in most of them, we know in 99%, there is a gross asymmetry between the two eyes, and trying to reduce this asymmetry and anisometropia would improve the quality of vision. Thank you.
Thank you, Dr. Sangeeta, for that comprehensive coverage of cross-linking, when to do, when not to do. So the take-home message would be the best protocol to follow, or the most popular one, is 9 milliwatts for 10 minutes. AP off is the preferred mode, and you can consider combining laser PTK or PRK mode with cross-linking, but one has to be very, very careful while offering this procedure. What I have noticed in your study, the two arms which you shared, the wavefront guided and the PRK group. So on an average, the flattening achieved is around 1 diopter, 1.25 diopter in the sphere, and not more than 2 diopter in the cylinder. So even if we do not do a PRK or a PTK mode and only do a cross-linking, we still can achieve the same amount of flattening. The only thing which makes a difference is regularization of the surface, which will not be seen with pure cross-linking. So when you talk of gain in visual acuity, the best corrected vision pre-op was say somewhere around 612. So this 1 line gain or 1.5 line gains in the post-op period. So whether it is really justified doing a refractive procedure along with cross-linking, or can the refractive procedure be done after cross-linking? That is the question. A minimum amount of ablation which you did in the primary procedure around 30-40 micron, can we do it after the cornea has been cross-linked? Any thoughts on that?
So let me tell you what my stand was. I am basically a very conservative person. So initially we started with ablation of 20 microns, then 40 microns. And we haven't dared to go beyond this. But looking at these results, we are encouraged to try and offer a little more correction. And that's why, so initially I would have That's where I was a bit disappointed, where we almost got just about a 1 or a 1.5.
Yeah.
But what is interesting to see is that the quality of vision and the patient satisfaction after the procedure was more. And again, we felt that the wavefront optimized will offer a much better recovery. And in that, again, we found that the aberrations were less. But if you look at the aberrations and the Zernicke in the post-PRK group, it was very, very encouraging. And that, in fact, I think is what adds to the improvement in the quality of vision. So maybe it's not a very good tool for a refractive change because we are not ablating more than the limit that we have set. Like there are people who go up to 60 to 80 microns. But like I said, we don't want to put the cornea at a risk. So we've kept our own cutoff at 40 microns.
Good.
But we found that the quality of vision is better because the aberrations have reduced. And basically, that is what we are offering to the patient. Whether it can be done after cross-linking, I would worry more about chances of haze. As it is, we see haze after even the standard cross-linking following Dresden protocols. In fact, I saw more haze after the Dresden protocol than accelerated. So that would be my main concern. In fact, what we offer stable cones after cross-linking 2 years later is a phakic IOL for a refractive change for the high errors.
May I add another thing, sir? Sir,
Yes, sir.
as we know that in keratoconus, it's a irregular astigmatism which has a larger role to play as far as the quality of vision is concerned. So what we are measuring before and after the PTK with CXL is only the component which we can measure, but not entire irregular astigmatism. So that is why it's the irregular component which improves significantly after these procedures, and that improves the quality of vision of the patient.
Okay. Any other comment on this?
Yes, sir. Can I make a comment on CXL in thin cornea?
Yeah.
So just for the comprehensive ophthalmologists who may have tuned in, that the idea of doing the CXL in thin cornea is when we say 400 microns, that is after epithelial removal, it should be 400 microns or more, which means that on any pentacam actually be close to 450 microns when you include an average epithelial thickness of 50 microns. So after removing the 50 microns of epithelium, if you have 400, then you can go ahead with using the standard solution that was used in the Dresden protocol. Otherwise, you should modify your technique to artificially inflate the thickness of the cornea using hypertonic solution or whatever other procedure you may prefer. So can I ask the panel what they prefer in terms of thin corneas, and till when actually you can cross-link? Because when you look at the calculators, even with a thickness of 200 micron, they will tell you do the cross-linking. But I don't think it's a wise idea, because it can give out a slightly wrong misconception that that the cross-linking is.
I think he's
There
frozen.
are complications that can occur. So I'd like to know from the seniors as to what is the post-epithelial removal corneal thickness that they would, beyond which they would not cross-link, where 360, 370.
I would stop at 380.
Okay, after epithelial removal, ma'am?
Or 350 is the lowest I have gone.
After removal,
I also had a protocol that we followed where we put in sterile water in the outpatient after putting proparacaine, but I till date have not been able to document any increase in the thickness after that. So even after 20 minutes, we find it's the same. So we just go to using hypotonic saline and hypotonic riboflavin and continue with the process.
So how is the experience about modifying the fluence energy in those patients, like total energy rather than 90? Like there was a sub 100 protocols you showed, right? So we decrease the energy, total amount of energy delivered based on the corneal thickness after soaking. So have you tried that?
No, so that is what is proposed by this nomogram or the calculators,
Exactly.
but we haven't yet tried it.
Okay.
I think it is easier to reduce the duration using the NN calculator actually, because I don't know how all machines work, but our machine, we have set limits. So you can give 3, you can give 5, you can give 7, like that. It goes in steps. So it's much easier to reduce the duration. rather than the fluence. But I think what I was trying to say was that essentially that we should not try to cross-link all thin corneas beyond a point, because we have to understand why we're doing the cross-linking, and that in spite of the cross-linking, if the vision continues to remain suboptimal, then we really need to consider whether there is an alternative procedure that is available, or maybe a referral to a cornea specialist would be the right thing to do at that point in time.
There is one more thing we put in our protocol in the pre-assessment, that every patient undergoes a contact lens trial before he is cross-linked. And only those who are going to, I mean, if the spectacle corrected visual acuity is 6.9, we'll go ahead. If they remain at 6.18 or so, we do a lens trial. Because the idea is post cross-linking, the patient should be visually rehabilitated. If you're not going to achieve any improvement in vision, then, you know, this is a patient I would consider for surgery instead of cross-linking.
Yes, ma'am. Yes, exactly.
There was only one point that came to my mind when I was looking at the customized cross-linking. First, I don't have access to the machine. The only one that I have is that MMD in which you can mask. So, you know, in Pellucid, we cross-link only the lower part. But when they talk about the pathology being just a focal pathology, you know, how can you explain recurrences happening in a post-graft patient? How do you explain a pellucid developing in a patient of keratoconus? You know, I mean,
the whole
so
cornea is
which
abnormal.
patient?
Yeah.
Correct. In whom is the disease focal, and in whom is it going to involve the whole cornea? If we can find an answer to that, then, you know, we can rationalize the treatment.
No, so
So
the
I'm
whole
sure there
cornea
are
is abnormal.
studies.
Only thing is that the abnormality is more pronounced in the central or the inferior portion. That's why you get the recurrences at the graft-verse junction, even outside the graft-verse junction, even after DLK and PK. So
Correct. So that is exactly what I think.
one loud thinking when we are on CXL. What is the problem of cross-linking the posterior cornea? If you're doing cross-linking, when you say that even the posterior cornea is abnormal, what is the hitch in going beyond 350? When you have been documented that there is no significant endothelial cell loss with the procedure, even when you see the demarcation line way back than where you expected.
I think, see, we have seen patients who came with iritis post cross-linking. So we don't know whether, I mean, we need to look back and see whether they were thin corneas, and, you know, is there any evidence that you can trigger an inflammatory response deeper than the cornea in the uveal tissue or in the anterior chamber? So I think, you know, endothelial cell loss used to be the
temporary
primary
amenable
concern.
to treatment. Yeah.
Yeah, they eventually do settle, but then, you know, it's not good to see an iritis post cross-link.
Right.
I would worry about.
Ajay, can I say something? This is Praveen.
Yes. Welcome, Praveen. Welcome. Good morning.
Morning.
But
sorry, I'll keep my video off because I'm driving currently. Hopefully, I'll complete driving by the time I'm.
Yeah.
So audio is welcome. But I think 2 or 3.
Praveen, your comments, please.
No, 2 or 3 very important points that came up, and pardon my voice. My voice is bad. When you're thinking about doing cross-linking for a patient with keratoconus, it is not just about whether the patient is suitable for cross-linking or not. And like Sangeeta said, if after cross-linking the patient is going to be able to use a contact lens, then great, go ahead with cross-linking. But after cross-linking, we've had patients who've had cross-linking and then like, now what? Now we don't want contact lens. And now we are doing a DALC for those patients. So the cross-linking procedure is wasted. So from that perspective, I think we should think through the next few years of what is going to happen to the patient and what the patient is going to do, and then decide. If it's a young child and you don't want to intervene till at least a certain age, or you don't want the disease to progress, then I think even the limits that we have set for ourselves, the 400, all these things, we should try and go beyond those limits and try and cross-link those eyes, because the benefit is in the long term, that you don't want to intervene for this patient in the long term. So the thought process of the 400, 350, there are 3 points that are important here. Number 1, it's only the thinnest cornea that is at that thickness. And once you remove the epithelium, if you have about 350 microns, that is good enough to cross-link with your normal protocol. because the penetration of the UV from the surface is about 300 microns. So you still have a 50 micron margin. So to start with, if you have 400, you're good to cross-link almost any cornea. Secondly, the lower limit is dependent on what is the benefit of the cross-linking for the patient. If it's going to be useful, stop the progress in a very young child, then by all means, we should go ahead and cross-link without thinking too much about the consequence. The reason is the thinnest part of the cornea is only in, say, like a central diameter of like maybe a half a millimeter or so, and the rest of the cornea actually is quite thick, and the endothelium probably won't be affected in that area. So even if you cross-link, if you are willing to give up maybe a 0.5 millimeter zone of endothelium versus avoiding requiring a corneal transplant in a child, that still is a fair trade-off. So from that perspective, I think a lot of these things become hazy. And I think the third concept is we are told about all these rigid cutoffs and stuff about thickness, right? But collagen cross-linking is not a precise procedure. You have, unlike a laser, the amount of cross-linking you're going to get is going to be variable based on the riboflavin, the kind of cross-linking machine you're using, the patient factors, the focusing, so many things. And the cross-linking also is over such a long period of time that even with the patient breathing normally, the head is going to go up and down, and you're going to have cross-linking occur deeper or shallower than what you would imagine. So I don't think we have to be so rigid about thinking that these are the absolute cutoffs for cross-linking. And also, like some of the riboflavins with dextran, they tend to thin the cornea more than what it was preoperatively. So that also is a problem. So I think bottom line is, if somebody is going to benefit from cross-linking, you should find a way of doing it, either with a contact lens or with a stromal lenticule or anything of those sorts. If a patient, if the patient is not going to benefit from cross-linking, whatever the thickness is, you should not do it. I think that's the more practical answer than about these numbers and these cutoffs. Sorry for the long.
Yeah, fair enough. Point well taken, Praveen. Thanks for your input.
Yeah.
Okay, I need to leave, Ajay. They're calling me downstairs.
Yes, sure. So with this,
I'll be back. Thank you so much.
Yeah.
Thank you, everyone.
Yeah, Dr. Prabhat, now you can invite the next speaker. Thanks, Dr. Sangeeta.
Thank you. Bye, everyone. Sorry to be late.
The next speaker is Dr. Kavita Rao, who's a cornea, cataract, and refractive surgeon at Aditya Jyot Eye Hospital of Agarwal's Eye Hospital in Mumbai. And she'll be speaking about something that is now, gaining more interest and more traction as we go along, KERS and intrastromal, biological stromal augmentation. Dr. Kavita.
Very good morning. My slides visible?
Yes, please go ahead.
Okay, thank you. So I think all of us, when we are managing keratoconus, Dr. Sangeeta also has spoken in detail about cross-linking, and not that every patient needs to be cross-linked. So we look at this flow chart, and this is what we follow, whether there's progression of keratoconus, and then we look at the corneal thickness. So this was what we was initially, before I started doing KERS, I was also a big proponent of doing, topo-guided PRK and doing cross-linking. But I feel more and more now, a lot of those patients have come back to me with repeat ectasia. So I'm more in favor of doing augmentation with KERS and cross-linking, even in maybe not very severe cases, and doing cross-linking rather than doing the laser-based procedure like Dr. Ajay Kulkarni was also mentioning. So what exactly is KERS? These are corneal allogenic ring segments. They're inserted in the mid-periphery, and they're inserted much closer to the visual axis versus intacts, and they're inserted more superficially. So what are intacts? So for people who've been doing, I had been doing intacts maybe about a decade earlier, and I did it maybe around 10 to 20 patients, not too many actually. So intacts, as we know, they are inserted much deeper, around 70 to 80% depth. We need a minimal corneal thickness of 450 at the site of placement, and here the optic zone needs to be much larger, around 6 to 6.5, though the Kera ring does need a smaller zone like 5 millimeter, but that can cause glare because it's not biological tissue. So the surgical procedure in Intacs, the channels are made using your femto, and the Intacs is then inserted into the cornea after opening up the channel. So the reason I'm showing this video is because, in fact, the placement of KERS is also pretty much a lot like just like your Intacs. Here you can see that this is how the Intacs has been placed. Now, I'll just show you this case. I think you can see it's been done almost 12 years ago, 2013. This was a double symmetric ring which was used for this he was a young boy, almost 20 years old, and I got a good result with reduction in the cylinder as well as visual acuity improved. This is a patient who was post-LASIK ectasia. She has been, in fact, I don't have her pre-op reports, but this is her post, the recent reports, almost like 6 months back, and she's been also done almost 10 years ago. And she has improvement in her vision. She was 6/18 earlier, and with a reduction in the refractive error as well as improvement in vision. Now, what is the problem with Intacs? Obviously, it's expensive. I felt that there were unpredictable refractive outcomes, and as you saw in this patient, you can get these deposits, which of course are innocuous. It doesn't bother the patient. It just bothers you when you're looking at it each time, and of course, you have serious complications like extrusion. So that's why KERS can be used in much thinner corneas, almost 300 to 350 microns. I have done KERS. They can be placed much closer to the visual axis, almost 4 mm, 4 to 4.5 the optic zone. And they also placed more superficial, so you get more effect. Obviously, it's more economical. There's no risk of extrusion. Now, how is it done? This is the set of instruments which are available for KERS. It's the tree fines which are available, the KERS tree fine. There are multiple measurements to the tree fine, 6.58, 7.75, 8.75. So what exactly, how is it done? So this is, like before you take the patient up, you're preparing the tissue for, you're removing the endoepithelium first. You don't really need to mount it on the artificial anterior chamber, but it makes it easier. So just remove the epithelium completely. Then you remove the endothelium, and after that, once the endothelium is removed, you use the tree fine and you punch out the tissue. This punching out the tissue is done with the tree fine, as you will see. Yeah. This you can use any of the tree fines. The thicker, the more periphery that you go towards, like tree fine, you take the larger tree fine, you get much thicker cornea. So this is a ring which you take, and here you're marking the tissue before you remove it from the tree fine. You mark it because that's actually the Bowman's layer. So now that you flattened out this tissue, the tissue is actually now inverted horizontally. So it's not like you're placing it superior to inferior into the cornea. Now this is actually kind of been transposed 90 degrees. And the blue area which is marked is actually the Bowman's area, which is then you can just use this, kind of a artificial globe to decide which area you want to place it and then fashion the tissue accordingly. This tissue can be then fashioned and can be kept, in the OR, and it dries up and almost becomes like intact. This is the planning which is done preoperatively. As you can see that the, optic zone is almost just 4.6 in this patient, which is quite close to the visual axis. So now patient, the channels are made pretty much like, in fact, just using the Intact software itself, the channels are made. Even if you're placing only one ring, the entire channel is made because that's how the software is. And here you can see that the tissue is almost dried up. On the lower surface, you can see almost becomes like Intact while placing it. It's very easy to place it. There are these set of instruments, which is the Y hook, and then there is a reverse Sinski, which helps you to, from the other side, you can just go and, place the like the segment wherever you want to. And if you feel it is longer, you can probably pull it back and, also refashion it. But typically, if I feel it's longer, I just bunch the tissue in like more like an augmented KERS. I don't, reduce the length of it. So this is how you place it, and you can use a reverse Sinski to, complete your placement. So does it work? So obviously this has been started by Dr. Susan Jacob in Chennai, and this is the papers which she has published, and she's found this 20 eyes. There was improvement in the best corrected visual acuity, as well as, reduction in the keratometry. But in all her patients, she did cross-link them after care. So we don't know, that's obviously a confounder where she's not really published patients where she's done only cares, or, she's done cares after cross-linking at some point. So we know whether it's only the cares which is acting and not the cross-linking also. So this was my, I'll just be sharing a few cases. This is a patient with, as you can see, almost 50 diopters of, corneal curvature, and best corrected vision was 612 with an increase in spherical as well as cylindrical powers. You can see now this patient ideally could have undergone TPRK and cross-linking, because best corrected vision is 6/12. But like I said, I was keen, I'm going more towards doing augmenting surgeries now rather than doing laser ablative. And here you can see that there is a visual improvement in the visual acuity as well as reduction in the cylindrical number. I'm much happy, and the patient is very happy with the vision. This is one of my very recent cases. You can see this vision, it's a pretty large cone. He's 6/24, his visual acuity is improved to 6/9, 6/6. And it's a large segment which I have used. This patient is about 6 months follow-up. Most of my follow-ups are about 6 months to around 2.5 years, because that's when I started doing the procedure. This was, in fact, I think one of my first patients. He was 19 years old with very advanced ectasia. As like Dr. Sangeeta was saying, if it does not improve, why should you even cross-link this patient? And when I saw this refractive error and so much of difference in both eyes, I almost thought maybe it's kind of like an axial myopia. But I did the axial length in both eyes, it was the same. So it was just the keratoconus. And we did a contact lens trial. At that point, he did not improve beyond 6/18. But he still decided to go ahead with cares, and we did a large segment cares. And though his best corrected vision stays 6/18, there's a marked reduction in the cylindrical and spherical number. And now with the scleral lenses, he has come to 6/9. So I think it's worthwhile, because it's an augmenting surgery. You're not doing TPRK, you're not ablating. I think this is definitely worthwhile exploring even in the severe cases. This was another patient with pretty advanced keratoconus. Again, the vision was 6/18, and best corrected improved to then 6/9. This patient, again, with 6/9, this patient was 6/6. This patient was actually post cross-linking, and not happy with the quality of vision. So this patient ideally did not need cares, but because it was post cross-linking about 7 to 8 years, we decided to do cares and see if the patient's vision improved, and the refractive error quality of vision improves, and he was pretty happy with that. This was another patient. You can see much 6/18 is his vision, very severe keratoconus, and definitely improvement. This is another patient with TPRK cross-linking done, I think, around 7 to 8 years ago, with a very thin cornea, 375. She's been using scleral contact lenses, not very happy with the vision. We did cares, and not only her vision improved, also the keratometry powers you can see went down. This again, a patient with very poor vision, 2/60, and now has improved to 6/18. So yes, these patients, maybe they may not really improve too much, but at least from 2/60, if they're going to 6/18, 6/12, I would say it's worthwhile. This was a patient with post-LASIK ectasia. Again, obviously it's post-LASIK ectasia. You're not going to do any ablative procedures in them. Patient's improvement from 6/18 to 6/9, and also the keratometry you can see has improved. So where does it fit? I feel with me more and more, I'm tending to do it even in less severe cases, because additive surgery is always better. Long-term results, of course, remain to be seen, because we don't know if it's going to thin out. But because we're using full thickness donor tissue, I would say it's more like a customized DALC. You can place any number of segments. And if you can also use femto. I think Dr. Rajesh Fogla uses femto to also fashion the segments. So long-term results are awaited, but I definitely feel it's here to stay. Thank you.
Thank you, Dr. Kavita, for this talk on exciting new development in management of keratoconus, especially when the cones are very high and utilizing a biological tissue. But what is interesting is that we are adding the tissue, but not in the zone which is thinner. Basically, it is around the base of the cone and trying to pull the cone down and make the cornea flat. So thank you very much for sharing your cases. Any other comment by the panel or anybody? Dr. Swapnil?
It was an excellent talk, Dr. Kavita.
Thank you so much.
Yeah. So is it possible to do this using manual in-text refines for those who do not have
Yes,
femto?
it's possible. I think there's, I forget the name, forget his name, Dr. Jack, I think in
Parker.
Jack Parker. Yeah, he uses manual, the manual refines.
Thank you so much.
Thank you.
Okay. So with this, we move on to the next talk. Would invite Yashwant, the dear friend, who will be talking to us on contact lenses in management of keratoconus.
Thank you, Ajay, and thank you, VOS, MOS, Dr. Shirish, and Dr. Shamik for having me here. So after all you guys manage the progression, prescribe drops to suppress the allergy, and once you're happy with stopping of the progression of keratoconus, then I step in and try to improve the vision further. And what best instrument other than contact lens to improve the vision? Now, when it comes to contact lenses, 2 + 2 is never equal to 4. Sometimes, when you see the key readings and you decide, okay, this is not a patient for contact lens, but when you actually put the contact lens on the patient's eye, you see improvement. So whenever we mention keratoconus, one thought comes to mind is specialty contact lenses. It could be scleral lenses, mini-scleral lenses, RGP, Dorex. But I think you can start with the basic, which is the soft contact lens, the regular contact lens. And if they are of the earlier generation, which are slightly thicker, which are having slightly higher modulus of elasticity, these lenses perform even better. Well, you might upgrade to a toric soft contact lens, and all these materials have to be silicone hydrogel lenses for increased oxygen transmissibility to the keratoconic cornea. And then you have the specialty soft contact lenses called as the KERASOFT, which are specifically meant for keratoconus patients. Now, these lenses differ a lot from the regular contact lens because the base curves essentially have to be steeper. The modulus has to be higher. And what we need to assess is the stability of the vision. Sometimes, the patient can read 6/9 on the chart, and we are pretty happy with it. But how happy is the patient's quality of vision? That is very, very important. Because these patients often have high order aberrations and they see ghostings and double vision, which can be very irritating for the patient, and the patient eventually goes into a dropout. Then the next is the RGP contact lens. I think it's a very well-established contact lens in treatment of keratoconus or when it comes to providing clear vision to keratoconic patient. The regular RGP contact lens, the routine Liffit RGP contact lens, which we fit on the flatter meridian, it actually stabilizes very well in cases of early keratoconus, and the steeper meridians are neutralized, or the negative cylinder is neutralized by the tear lens, which is formed between the contact lens and the cornea. Sometimes you might need a back toric contact lens for the lens to stabilize and center very well on the cornea because the toricity, especially the peripheral toricity, is very high. And if there is an internal astigmatism or astigmatism because of the posterior keratoconus, you can use a bitoric RGP contact lens to provide clear vision to this patient. Then you also have an option of specialty RGP lenses. It could be your sclerals, mini-sclerals, corneoscleral lenses. All these lenses are available in the Indian market today. You would have heard of the corneal lenses called as Rose-K, which is very commonly prescribed in India. Then you have the Manicon lens, and I'm sure there are more number of lenses eventually will be available in the country for treating keratoconus. Some certain tips about fitting of these lenses. Normally, when we see a fluorescein pattern which is occurring on the left side of your screen, if you see like that, there is a nice clearance, there is a nice area of pooling between the cornea and the contact lens, you're very happy with the fit because you are no way touching the cornea, your cornea is safe. But these lenses do not offer very good vision rehabilitation. because until and unless you put a little bit of positive pressure in the central cornea, the vision improvement is not to the patient's satisfaction. So it is always said, there should be a feather touch. Now, when I say touch, the cornea specialist may not be very comfortable hearing that word, but it's a feather touch. There is still some fluorescein between the contact lens and the cornea. Now, these lenses offer a slight amount of positive pressure on the center, push the cornea down, and the vision improves. So if you find a fit on the left side, something like on the left side, and if the vision is not improving, just go a little flatter and you will see that the vision improves by 1 or 2 lines. Next comes the edge fitting. Now, center and edge, these are two most important parameters to be assessed when you're fitting corneal RGPs. Now, we know the cornea is very steep in the center and it rapidly flattens as we go towards the periphery. So fortunately for us, we have these standard edge lifts available. So when you have a trial set of specialty lenses, you have the lens trial set in standard edge lift, which you can modify to make it more flat or to make it more steep. Generally, flatter is more required, and that is why you have an option of 0.5 flat or a 1, 1.5, 2, and 3 flat. And when it goes on the steeper side, it's 0.5, 1, and 1.3 steeper. Very rarely you need to steepen the edge lift. And 85% of your cases can be fit with a 0.5 steep to standard and a 1 diopter of increased edge lift. So it's a very simple calculation. Only in using the trial set and few parameters change, you can successfully give a corneal RGP to a keratoconic patient. Now, if you see this image, this is an ideal fit. There's a feather touch in the center, and there is a decent amount of edge lift. It is not too much, it is not too less. If you see the second image, the edge lift is really bad. The lens is really lifting up. Because of the upper lid is holding the lens and pulling it up. So the lens is superiorly getting decentered. So you have to reduce the edge lift here. And if you see here, the edge lift is really less, because of which there is no traction between the upper lid and the contact lens, and the lens tends to sag down. So the lift has to be optimum. It should not be too much. It should not be too less. And this is how we can adjust the edge lift. And these can be adjusted in terms of 0.1 steps. So it can be 1, it can be 1.1, 1.2, like that. Now, many of these patients have peripheral toricity, and sometimes this toricity can be really bad, and it doesn't allow us to fit a spherical contact lens, a spherical RGP corneal contact lens on this cornea. So sometimes you feel the need for having peripheral toricity, and fortunately for all of us, these lenses are available in India, and you can have these toricities in steps of 0.4 to 1.3, and sometimes if you request the lab, it can be made in highly toric as well. Now, this works very well to stabilize the contact lens on the cornea. The center is spherical. The periphery is only limited to the toricity is only limited to the periphery of the contact lens. So fitting becomes easy. It is more cost effective. Centers very well. It fits almost like your spherical contact lens, and the vision correction is very good because the central astigmatism is taken care by the tear lens. The peripheral toricity is only for stability of the contact lens on the cornea. For people who are routinely doing corneal contact lens fitting on keratoconic corneas, you will often encounter images like these, wherein you feel everything is good. It is only the 6 o'clock area which needs to be tucked in. Now, fortunately for us, the 6 o'clock area tuck-in is available, and it is called as asymmetric corneal technology. So it is available in various grades. So you can have ACT1, ACT2, ACT3, like that, depending on the quantity of lift and the area of lift. Again, relatively very easy to fit, provides much better alignment. The patient is very happy. Otherwise, the patient starts getting this ticklish feeling at 6 o'clock. So the patients readily accept the lens once you have an ACT lens. Customization in RGP, very, very important because no two corneas are same. And when we have to customize, the most important aspect is the diameter. Some people will say, use small diameter lens. Some people will say use a larger diameter lens. But if there is a peripheral toricity and you use a large diameter lens, the lens is not fitting very well. So sometimes you might decide to fit only on the cap, which is about 8.4 millimeters or even 8.1 millimeter, a very tiny RGP contact lens. And if you still want to fit a larger contact lens because you want the lens to center very well and fit very well, then you can give peripheral toricity. So larger diameter lenses can be up to 10.5, 10.6 as well, and smaller ones can be 8.1, 8.2, 8.4. The lenses are designed in such a way that the center is pretty steep and it rapidly flattens as it goes towards the periphery. So the E value used in the contact lens is really high because of its keratoconic shape. Aspheric surface is something that is very, very useful when it comes to keratoconic contact lenses because they take care of some amount of aberrations and the clarity of vision improves. And certain sets, especially in cases of scleral lenses, you can have varying eccentricity values in the trial set. So once you achieve a good fit, then you try an eccentricity 1, eccentricity 0, eccentricity 2, and see what lens or what eccentricity offers you the best vision. Toricity I've already discussed, and very, very rarely you need an FBSC lens, which is a full back surface toric. So the toricity is starting from one edge and goes on to the center and to the opposite edge. So certain things that we need to remember when it comes to assessing the fluorescein pattern. If there is fluorescein between the cornea and the contact lens, and it is to a level of less than 20 microns, then it will not fluoresce on slit lamp. You will not be able to see it. And you might feel that there is a frank touch, but the cornea doesn't get damaged because there is still some fluorescein. So anything in excess of 20 microns will be seen on slit lamp. And anything in excess of 90 microns will actually give rise to an air bubble. So now you know how to judge how much of fluorescein is there behind the contact lens. And if you don't want to judge, you want to be very, very accurate, then you can use the topo-guided contact lens fitting. Now, I have a Medmont E300, which is the world's best contact lens designing corneal topographer. And instead of putting multiple lenses on the patient's cornea, I just do a corneal topography, and whatever lens I want to dispense, I click that and it gives me the most accurate fit. And when I go on to, when I place my cursor on the center, and if I see that there is a fluorescein of about 40 microns and I want to reduce it to 20 microns, I can virtually change the contact lens on the screen rather than actually on the patient's eye. Similarly, if you see at 6 o'clock, there is too much of fluorescein pooling here. So the topography will actually tell me whether I should use an ACT1 lens or an ACT2 lens to get a very good fit. Now, on the left is the topography simulated fluorescein image, and on the right is the actual fit. That is how accurate it is. So it becomes very easy to fit these specialty lenses if you have a corneal topographer and a specialized software for all the brands of lenses that are available in today's world. Boston lenses, scleral lenses from Boston Foundation are manufactured in India at LV Prasad Eye Institute. They have a fantastic lab, and these are the only international standard contact lenses, scleral contact lenses available in the Indian market. And they have two variants, which is the Boston Sight Sclerals and the Pros device. A Boston Sight Scleral is a mini scleral lens, or sometimes it can be 18-19 millimeter lens as well, with an advantage of customization possible at 4 quadrants. So superior, inferior, nasal, temporal. So at 4 quadrants, I can change the edge design, I can change the limbal vault, I can change the central vault. But sometimes corneas are more irregular and you need possibilities of more adjustments. And that is where the Pros design comes in, wherein I can change the lens design at 8 meridians instead of just 4 quadrants.
Yes, sir, can we just wind up quickly?
Yeah, sure. I think these are the last couple of slides only. And these have a facility of channels and haptic modifications which can be done. The impression sclerals, which very much work like your dental impressions. You take an impression, a mold is generated on this computer screen, and a lens is manufactured to fit like a hand-in glove. Corneal topographers can be used to assess the initial trial lens because research conducted at Pacific University show that the keratoconic changes are up to 10 millimeters of chord, and beyond that, the corneas are pretty much similar to normal corneas. So we know the difference between 10 to 15 millimeter chord is 2000 micron. And once we have this sag depth, you add 2000 microns and the clearance that you need in a lens, and you can actually select the first trial lens based on corneal topography, or you have the scleral profilometry, wherein the topography goes up to the scleral level, so you can design very accurate contact lenses based on these instruments. And these are some mentions: the Synergy Eyes lens, which is a combination of rigid and soft, and you have the piggyback lens. These lenses are not very commonly used these days because scleral lenses work wonderfully well. So that's all from my side. I hope the presentation was useful in giving you some insights about contact lens fitting in keratoconus patients. Over to you, Dr. Swapnil.
Thank you. That was an excellent presentation, Ashwinji. Any comment, Dr. Ajay?
Now we can go ahead with the next talk.
Yeah.
Yeah.
So next talk is by Professor Vijay Sharma, who is a pass out of AFMC Pune. He's a professor in AFMC Pune right now, and he is a pass out of AIMS Delhi. So he will be talking about the surgical management of keratoconus, whether to go for DALK or PK, and what are the troubles in each of the surgery. Dr. Vijay, over to you.
Yeah, thank you very much. So first of all, thanks to MOS and VOS for giving this opportunity. So I'll be talking about transplant troubles, whether DALK or PK or which type of keratoplasty should be done in keratoconus. So now, if we see over last decade, there has been a decreasing trends in keratoplasty. This is predominantly due to my slides are visible. Are they moving? Okay, fine.
Yes.
Okay. So there has been decreasing trends. Now this is predominantly because of availability of corneal cross-linking and other intracorneal ring segments and contact lenses, which can improve the visual acuity in individual who has marked diminution of visual acuity due to keratoconus. But still around 20% of the patients, they end up requiring the keratoplasty procedures. In recent time, there has been a paradigm shift towards DALK from penetrating keratoplasty. This is due to the better graft survival. In one study, French study that found that it's around 3 times longer graft survival in DALK compared to penetrating keratoplasty. So during the talk, I'll try to answer these following questions. When should we consider corneal transplant in keratoconus? Which procedures to choose, DALK or penetrating keratoplasty? What technique to choose from for DALK, whether it's a big bubble or a manual, and the role of MIOCT and various femtosecond assisted surgeries. So this is a protocol for surgical management of keratoconus that we normally follow. An individual who has got extremely poor visual acuity and who is intolerant to contact lenses, and rest of the measures have failed to improve the visual acuity. We look for central scarring. If there is no central scarring, then patient is usually either planned for a Bowman layer transplant or intrastromal augmentation, tissue augmentation techniques, or we can do a DALK in these patients. If there is a central scarring, whether it is associated with hydrops or there was no previous hydrops. If there was no hydrops, in such cases, we can go ahead with big bubble technique for DALK. But if there is a hydrops, then we cannot go ahead with a big bubble, because big bubble will open the previously existing Descemet tear. If the individual has got hydrops, then if it is an acute hydrops, we go ahead and do the C3F8 or air injection in these patients. And once it resolves, then again we re-evaluate. If there is a significant scarring, we go ahead with either a manual DALK or a penetrating keratoplasty in such cases. This is one of our patients. So this was a 23-year-old individual, a known case of Down syndrome, who was having itching and watering in both eyes since childhood, and marked diminution of vision for last about 10 years. He was having severe pain in the right eye along with severe photophobia for last 1 week duration. And in this patient, the slit lamp evaluation could not be done. The corneal topography could not be done because he was highly uncooperative. As you can see how much uncomfortable he is at the ambient light conditions. So we subjected him to examination under general anesthesia. Now you can see the picture for the right eye and the left eye. The visual acuity was just perception of light in both eyes with accurate projection of rays. In the right eye, you can see there is a circumcorneal ciliary congestion and a diffuse corneal edema, which is involving the entire cornea, and diagnosed as a case of acute hydrops in the right eye. And in the left eye also, he had resolving hydrops, as you can see the Descemet tear, and also there was some amount of corneal edema around that, and also the patient had intumescent cataract. So the patient was planned for surgery in the same sitting. And in the right eye, in both eye, first we plan to do the AR or C3F8 injection. In this patient, we prefer the C3F8 because of the extensive hydrops that he had. So C3F8 was injected in the right eye. It was an isoexpensile mixture. And similarly, the C3F8 was also injected in the left eye, considering there was some amount of corneal edema in this, along with the scarring. So this was a resolving eye drops, but we cannot subject this patient again and again to anesthesia. So we went ahead and injected C3F8 in both the eyes. So after about 6 weeks, this was his condition. In the right eye, the vision was same. In the right eye, the eye drops had resolved, and there was a leukomatous corneal opacity, which was involving the full thickness of cornea. And in the left eye, you can see the amount of cataract that he had. So we've planned the surgery in the right eye. We went ahead with the optical penetrating keratoplasty. Considering the cataract in the left eye, we also expected that individual might have cataract in the right eye as well. So we went ahead with the same planning. After the 7.5 millimeter trephination was done, then we injected the trypan blue to stain the anterior capsule. And after removing the corneal button, we saw the pupil was non-dilating, and there were extensive synechiae which were formed. Extensive posterior synechiae were present, and he had a mature cataract or intumescent cataract, you can say, in this eye as well. So as pupil was non-dilating, we use a B-hex ring in this case to dilate the pupil. And once the pupil was dilated, that is the time we removed the cataract. And once the cataract was removed, sorry, I had a call in between. So once this was removed, you can see the cataractous nucleus which is coming out. Then we did a irrigation aspiration, removal of the cortex, and an intraocular lens was placed in the back, as you can see in this. And then the donor cornea button, which was of the same size, considering the status of the keratoconus, that was sutured in place. And this was the other eye. In the same sitting, we did the cataract surgery for the other eye. This was an intumescent cataract. Again, there were extensive synechiae which were present. And as soon as we did the first nick, it was trying to expand, and sort of Argentinian flag sign just stopped short of that. So we went ahead. We did some removal of the liquefied cortex, which was present. Synechiae were broken, and also we had to use MVR scissors intraoperatively to complete the rhexis. And once the rhexis was done, then the cataractous lens was subsequently emulsified, and an intraocular lens was placed in this eye. So this eye was left like this because in the visual axis there was some area of the clear cornea which was available. And once the intraocular lens was placed, then the wood was hydrated, and this is how it was closed. So a case like this where there is a full thickness corneal involvement, there you have to you have no other option but to go for a penetrating keratoplasty. Now this is another case where there was a eye drops. On ASOCT, we could not see exactly the location of the eye drops, so we went ahead and planned a MIOCT guided DALK in this patient. And we went layer by layer. First, we removed the anterior portion of the cornea, significant thickness of cornea around 250 micron, before going for a further finer manual dissection. And it was guided by the microscope integrated OCT, as you can see. Along with that, the appearance in the microscope integrated OCT. Now, MIOCT can be very helpful in such conditions where there is a eye drops. So over the above the area where there is a descemet rupture, you can leave some amount of tissue and some amount of stromal tissue so that it doesn't open up, and you can actually successfully do a DALK in such cases as well. So this is now we have exposed the descemet at one place, then a lamina was created, viscoelastic was injected gradually and gently, and subsequently we could finally expose the entire descemet membrane, except slightly inferior part where there was a break in the descemets due to the eye drops. So this is a final appearance before we put the donor tissue, and we could expose the entire descemets on this, and this procedure was completed. and then 16 interrupted switches were placed. Now, this microscope integrated OCT as well as the femtoseconds, they can be a very good adjuncts for a successful outcome in such cases where you do not, because otherwise the perforation rate in DALK is very high and conversion to PK is also very high. But MIOCT as well as the femtosecond, they can be very, very helpful adjuncts to prevent the complications in such surgery. So this is another case where there was around 350 micron of scarring anteriorly. So here we went ahead with a femtosecond assisted DALK. So we did a around 400 micron depth. We applied the femtosecond, and it was around 7.9 millimeter. Diameter was cut, and gently we removed the tissue. And after the tissue was removed, then a donor lenticule was placed, and that was sutured in place. So this way we could using the femtosecond in this case. Also, in many cases, what we get is there are some scarring in the anterior aspect of cornea. So those scarring in keratoconus can be either post-CXL infectious keratitis, where they are involving only the anterior 100 to 200 micron. In these cases, we can do the sutureless anterior lamellar keratoplasty using the femtosecond, because we want good visual rehabilitation of these patients. So this is a donor cornea being prepared for the for a patient who had a significant scarring, which was involving up to around 150 micron. So a side cut angle was made. As you can see, this is after applying the PI and patient subjected to femtosecond cutting. So side cut was around 45 degree instead of routine 90 degree. And once the recipient cornea was removed, the scarred cornea was removed, then the donor cornea was placed back in position. Side angles are around 45 degrees, so we can tuck in and we can do a tuck in femtosecond laser assisted anterior lamellar keratoplasty in such cases. We just have to apply the glue. Even without glue, they stay very well, but BCL has to be applied for about 3 weeks, and we can achieve a good clearing of the visual axis by these techniques, and patient can be visually rehabilitated in such cases. So I think with this, I would like to conclude. So there is a decreasing trend in keratoplasty, which is a good sign. That means the other modalities, they have picked up and they are quite effective in stopping the progression of keratoconus to such a state that it will require a keratoplasty. As far as the keratoplasty is concerned, the DALK is the first option if all indications are okay. And the MIOCT and femtosecond lasers, they can potentially improve the outcome and decrease the complications. Thank you very much.
Thank you, Dr. Sharma, for your talk, specifically mentioning about how to choose a procedure of looking at the clinical condition, when to choose a big bubble and a manual technique. And the femtosecond and the microscope integrated OCT, there is a big help. But all of us do not have the access to these modalities.
Yes.
But thank you once again for giving us the algorithm about how to choose the procedure. Thank you very much.
Thank you very much.
So with this, I now invite Dr. Praveen, who will be talking to us about a new kid on the block. I'm sure it's not kids' play. Praveen, please.
Thank you very much, Ajay, and also the VOS for this kind invite. And I think I was listening into some of the talks and some very, very nice and also very informative talks so far. What I'm going to be speaking to you about in the next 10, 12 minutes or so.
Praveen, can you increase the volume? You're not audible.
Is this, let me just change my.
But it was better in the Volvo.
Is this any better? Can you hear me now?
Yeah, please go ahead.
Okay, I'll just turn off my video because I think that'll help. So what I hope to convey in the next 10 minutes or 12 minutes is what to look forward to in corneal transplant surgery without actually doing corneal transplants, and what we can do to avoid doing a keratoplasty in patients who have keratoconus. So very quickly to talk about how this has become important to all of us in our clinic. The number of patients that we are seeing every year, and now in fact almost every week, and several new patients every day, has changed quite a bit over the last 30 years. And we're seeing more and more patients coming with keratoconus that has been newly diagnosed. We also started looking at the type of procedures that these patients undergo. And though a large number of patients, even more recently, are managed by contact lenses, surgical procedures have become less and less common with the advent of more frequent cross-linking. So as we cross-link more patients, the number of patients who require PK or DALK has come down. The other interesting aspect is we've also seen a reduction in the age at which keratoconus patients come for. Are you able to hear me all right?
Yes, yes.
Okay. And also it seems that there are more patients who now present to us who are younger than 20 years. And in fact, very recently we published a series of patients who are even less than 12 years who had keratoconus when they presented to clinic. So for all these reasons, we probably need to start to expand our armamentarium of surgical procedures available and try to look for alternatives that are more definitive. So here is the typical kind of patient who this needs an alternative. You have a patient who has good vision in one eye, 20/40, improving to 20/20 parts with spectacles. The other eye is very advanced keratoconus, as you can see on the topography. The thickness is very low, 355 microns. So, and this patient is unwilling to use contact lenses. And even if you prescribe contact lenses for someone who has good vision in one eye, they're very unlikely to use contact lenses because they are not dependent on this eye. So what is alternative from the point of view of doing an intervention in these patients? DALK is an obvious answer because that is something that, like Professor Vijay Sharma showed you, is a very successful. But then again, it might not be amenable, accessible, and also in many cases affordable for several patients too. So if you have the thickness is inadequate to corneal cross-linking, you think about PK or DALK for these patients. But if you have a young patient where you don't want to do PK or DALK, is there an alternative for these kind of patients where objectives are clear? You want to improve vision, you want to regularize corneas, you ensure that you improve visual quality. You also want to ensure the cornea is thicker, and you want to prevent progression of disease in the future as well. So it was at this time that there were options that started coming out, including Bowman's membrane transplants, which came in primarily from the Gerrit Malice's group in Netherlands. And they started to show that there was some improvement in the visual acuity of these patients, as well as reduction in the progression of the disease in these patients as well. So we also started to look at literature about what would be the appropriate tissue that could be transplanted or used to prevent progression in these cases. Smile lenticules as well, but smile lenticules have their own downsides. They're smaller in diameter, and they are also very malleable. They don't have the adequate amount of strength that will reshape the cornea or change the curvature of the cornea. This kind of background, we've had several years of experience with what we call corneal inlays. Earlier, synthetic inlays way back in 2004, where we implanted these inlays primarily to correct presbyopia, but they were not very successful because they all became ossified after some time, and they didn't provide very good visual recovery. We gave up this, but then we came across a company in Germany called Gebauer Medical, whose specialization was to manufacture equipment for both microkeratomes as well as for DSEC lenticules. And we started working with them. And the initial work was to try and get a lenticule that is shaped from the human cornea that could be implanted beneath a flap that affect hyperopia. We called this procedure live, and we had quite good results in patients who had high hyperopia. This is the patient who had the high adapters. And other than a lenticular extraction procedure or a lens exchange, there is really no other way to treat these patients. So these kind of corneal tissue within the flap of patient hyperopia, even 5-6 years later, it stayed clear and the patients had good visual acuity. But then we implant pocket in these kind of patients. So this is the patient that I
Has he logged off accidentally?
Lost the connection.
Okay. Should I have a word with him?
I'm calling.
Yeah, somebody from technical side also.
Okay.
Please look into it.
Mr. Sunil sir, please.
Hello. Yeah, you're trying to connect again, right? Yeah. Okay. Okay. All right. He's trying to connect again.
Yeah.
Okay. Okay.
What was the audience number? Technical team? Yeah, he's here. Yes, Dr.
Sorry.
Praveen, can you hear us?
I can hear you now. Can you hear
Yeah.
me all right?
Yeah, you can share your screen.
Yeah, I think the complication of having a webinar on Sunday when everybody is at home using bandwidth, I think is a problem. So I'm not sure where I stopped, but I'll not go back too much. I'll just start to talk about the patient that we started to think about doing an alternative procedure. This is the patient in question where we have very poor vision, CF 1 meter in the left eye, improving with a -7, -3.25 to only 20/200, not tolerant to contact lens wear. And we started to think about an alternative for this patient. So this is when we came across Xenia. Xenia is made by the same company that I was referring to, Gebord Meditech. And we helped them develop the initial implants, the size, the shape, as well as the configuration. And this was an implant that was between 50 to 100 microns thick, between 7 and 8 millimeters in diameter, and also cross-linked with UV to make it rigid, so it also can reshape the cornea and also give some amount of flattening for these corneas. So porcine collagen implants might sound like a far-fetched idea, but then what they did here was they tended to decellularize these implants completely with a special treatment process. And once this purified collagen was available, it was more a collagen matrix than a porcine collagen. And even then, porcine collagen has been utilized in the human body for several other uses as well, like cardiac valves, ear cartilage replacement, for tendon reinforcement, and the like. And there also have been publications about using porcine collagen for corneal transplants in the past as well. And we also looked at literature to find what is the optimal corneal xenograft by analyzing the kind of proteins that are present in different animals. And we found that the porcine collagen was the closest and it matched the human collagen the most. And that's why we thought that we'll go with porcine collagen at this point of time. So how Xenia is done, this is an animation. I won't show you a video, but then Xenia is done by creating a femtosecond pocket within the keratoconus cornea with a small incision. And the reason why a pocket is important is so that the walls of the pocket provide you that kind of structural strength to be able to retain the lenticule inside the eye. Then the implant is either injected or folded and put inside this pocket. And once it's inside this pocket, then it is unfolded and it is also regularized so that it is flat within the pocket. Pocket typically is about 9 millimeters in diameter, and this implant around 7.7 millimeters and is centered over the visual axis. So once this is done, then we actually just put a bandage contact lens, no sutures in the eye of these patients, and then we actually look at what happens post-operatively. So this patient, you see, this is the pre-op cornea, 1 month post-op after the Xenia implant. You can see the border of the implant, and then 12 months post-op after the Xenia implant as well, showing that the implant remains clear over an extended period of time. The other very exciting thing about this implant is that this implant also changed the curvature of the cornea. And even on the OCT, you can see that pre-op to post-op, the curvature is quite regularized. And then corneal topography, which was very surprising that we got flattening almost up to 35 diopters of the corneal curvature. So this was a device that was not only potentially regularizing the cornea, it was also flattening the cornea to near normal values, and it was also preventing progression over time. And we followed up this patient over a long period of time, and we found that even over 12 months, there was no change in the curvature of the cornea. So we went ahead and implanted these lenticules to several subjects as part of a study. And I'll give you a quick summary. This is the pre-op mean K for most of these patients were about 60 to 70 microns. And most patients ended up with a regularization of the K after surgery. And most patients also had a significant improvement in visual acuity also after the surgery. So it's not that we had complete 100% success. So there were some patients where even after implanting the Xenia implant, we had stromal melts or epithelial breakdowns on the surface, and we had to explant some of these lenticules. And they resolved completely even after the explantation of the lenticule as well. Corneal topography recovered to what it was before. But what was interesting to see that the majority of patients went down from the refractive error that was very high to a very low refractive error, and they also had good visual recovery as well. And in fact, this is a patient who operated in August 2021, picture from August 2024, almost 3 years after the initial surgery was done. And you see that the implant is still very stable within the cornea. Pocket depth is about 120 microns. And this patient continues to maintain the kind of flattening that she had even after surgery, and almost 35 micron diopters of flattening after surgery. And her visual acuity also improved from what I showed you, the CF 1 meter, to about 20/50. And that is actually quite acceptable vision in a patient of keratoconus whose only other recourse is a corneal transplant. So several people have asked us, why not use human collagen? Well, the supply of human collagen is limited. And also because of the immune privilege of the cornea, the porcine collagen probably will be quite well tolerated in the eye as well. So that is the reason why we believe that the Xenia stromal lenticule implant, which improves corneal curvature and visual acuity, is quite a good option for patients not suitable for collagen cross-linking. And it has the potential to avoid the need for a corneal transplant, and eventually will become a part of the algorithm to manage keratoconus. So I'll stop there. I'm not saying that this is something that is ready for use right now, but it is something that potentially will become part of all our surgical protocols and will become a quick, easy way of correcting keratoconus in the future as well. Thank you very much.
Thank you, Dr. Praveen. So one question is it really necessary to have a femtosecond to create a pocket?
No. The second group of patients that we implanted in, we did a manual dissection in the cornea. And
Yeah, if you
because
have,
we, yeah.
if you have a
And
guarded
that,
knife and you can create a
yeah,
pocket manually.
absolutely, absolutely
Yeah,
possible. And
only
that's
then
what we
that
did.
procedure will be it will be like available on a larger scale. Otherwise, if you don't have a femto, then it's a big deterrent.
Absolutely.
Yeah.
What I showed you was the first group of patients. Second group of patients were all manual dissection with implants. So no femto was used.
So did you find any difference in the interface haze in this group where it was done manually?
This group of patients, we were able to implant the lenticule even deeper than the femto. We implanted them around 200 microns depth. And I think What they also did was they modified the lenticule to make it about 30 microns thickness. So it did not have as much strength as in the first group, but compatibility wise, there was no difference in the haze between the first and the last group.
Okay. So this seems very promising because you are adding tissue to a already thin part of the cornea, and at the same time improving the topography, the curvature, not only of the anterior surface, but the posterior cornea as well. So this is very promising. It's interesting.
Thank you.
And any patients, these patients required contact lenses for visual rehabilitation, or all of them were okay with glasses?
No, all of them were okay with glasses. The only difference was initially when we tried to center the implant, we centered it on the visual axis. Then we realized that that was the wrong approach. We started centering it on the cone, and then we started getting better results as well, and they didn't require contact lenses after that.
Yeah, because when you look at the pocket, the relative position of the implant inside the stroma will be different in the superior cornea as compared to the inferior cornea. So that irregularity will be there because the thickness of the implant is universal from like edge to edge. So it is bound to have some difference when you compare topography in the superior hemimeridian as compared to the inferior meridian. But it's a good thing that none of the patients required contact lenses, and all of them could be rehabilitated with use of glasses. So that's a great plus. Any other comment or question on the Xenia implant? So if there are no questions, I would request Dr. Praveen to just summarize keratoconus A to Z, maybe 10 takeaway points, right from the clinical examination, the patient walks in, and rather than focusing on do's, I would like you to focus on don'ts.
I think, 10 points might be difficult to get through, but I think at least what I've learned with keratoconus patients over time is, number one, early detection is key. So I think there are patients who are misdiagnosed as amblyopia, astigmatism. So getting a topography done for these patients early on, you might not pick it up. If you have somebody with good refraction retinoscopy skills, that itself might be the earliest way in which we'll pick up keratoconus. So don't send them off just with glasses, and be very vigilant in the age group of between 10 and 15 years, especially because that is where they seem to present. Secondly, we don't tend to treat these patients actively or aggressively for their allergies. The ocular allergy is the number one reason why they progress. So very important to ensure that the ocular allergy is well controlled, and because if they don't have good control of ocular allergy, they can't even use contact lenses. Thirdly, I think contact lenses are a fantastic modality of managing these patients. And a lot of them, we don't need to be in a hurry to do surgery. We tend to do contact lenses, and they're usually very functional with their contact lenses. I think fourthly, the dictum that I've tried to follow is always try to preserve the better eye and do something surgical for the worst eye. So the better eye, try to do cross-linking early, especially if the child is young, because the risk of progression is higher in younger children. And in the worst eye, either give them a contact lens to buy time if they're in the age group where they don't require general anesthesia for surgery and suture removal. That's when we try to do either a DALC right now. In the future, maybe we'll do one of these other modalities as well. I think the other thing about keratoconus is cross-linking. Again, like I said earlier, cross-linking, try to do it as much as possible in patients where it will benefit. But again, doing it in patients who are not going to be visually rehabilitated, but by other modalities, I think it's not a good idea to cross-link everyone. I think that's where I'll stop.
And do we have a recent data on the outcomes of penetrating graft? Because the earlier meta-analysis where we knew that keratoconus is the indication where the graft success or a 5-year survival on Kaplan-Meier is the best in this group when you are doing penetrating grafts. Even the grafts which we had done earlier, maybe 10 years ago, 15 years ago, still are surviving. And
Yes.
do you have any comparative data on the outcomes of DALK versus PK in this group?
No, DALK versus PK, visually, they seem to be doing equally well. And even PK in eyes with keratoconus, they have exceptionally good survival. The
Yeah.
only downside of doing PK is the need to be on steroids for a long time and the complications that occur with steroids. Otherwise, PK survival rejection is fantastic, and even recent data shows that more than 95% grafts do well in 5-year time.
So thank you for your inputs and words of wisdom. I think that pretty well sums up A to Z about keratoconus. So I would like to thank the co-chair, Dr. Swapnil, moderator, Dr. Prabhat, and all the faculty for sparing their time on Sunday and enlightening us about keratoconus. So thank you, Praveen, for joining.
Thank you, everyone.
Thank you.
Have a Sunday.
I hand over to Chairman Scientific Committee, Dr. Shamik, and President MOS VOS, Dr. Shirish.
Thank you for wonderful inputs. It was really A to Z of keratoconus. I hand over to Dr. Shamik and Dr. Sriram for vote of thanks. Dr. Viral is there.
Hello.
A big thanks to all the faculty giving their time on a Sunday morning, especially when we all are celebrating the glaucoma week and the beginning of the glaucoma week, World Glaucoma Week. So I would like to thank everyone, including chairpersons Ajay sir, Prabhat, and Swapnil. So I'll now hand over the proceedings to Sriram sir and to present the vote of thanks. Dr. Viral sir is also here. He's our secretary for MOS. So I would also like to hand
Thank
it
you,
over
Shamik.
to either Viral
Yeah.
sir or Sriram
Yeah,
sir.
thank you,
very much.
Shamik. Yeah, before Sriram gives his official vote of thanks, I would like to thank Team VOS also for joining hands with the MOS for this wonderful Cone Chronicle A to Z about keratoconus. I would like to thank our national faculties, Dr. Praveen Krishna, Dr. Sangeeta Wagh Madam, Dr. Vijay Krishna, Dr. Kavita Rao, and our VOS faculty, Dr. Ankit, Dr. Anupam, Dr. Palak, and of course, our Mr. Yashwant Saoji. Thank you to the chairpersons, Ajay Kulkarni sir and Swapnil Bhalekar sir, and wonderful moderation by Dr. Prabhat. Over to Dr. Sriram for his official vote
I
of
would like
thanks
to
on behalf.
express, yes, I would like to express my heartfelt gratitudes to all the eminent faculties, Dr. Praveen sir, Dr. Ankit, then Dr. Wagh madam, Dr. Rao madam, then Dr. Palak, everyone. They have really given a very wonderful presentation on each and every aspect of keratoconus. I am damn sure it will this today's webinar will help us a lot in our routine clinical practice. Thank you, Dr. Ajay sir, Dr. Bhalerao sir, Dr. Pravas for coordinating this today's webinar very nicely and smoothly. And last but not the least, thank you all the viewers who have attended today's webinar positively, irrespective of Sunday. And lastly, I would like to thank Introde and team for their supporting technically for this today's webinar. Thank you all. Thank you, sir.
Thank you. It was really wonderful experience. Thank you, Dr.
Really
Sapnil
good.
sir. Thank you. Thank you.
Yes, sir.
Thank you.
Thank you, sir.
Thank you very much. Thank you.